as you all are aware, the United States just passed a dubious milestone in the fact that we now have lost at least 1 million lives to this infection over the course of the almost 3 years we've been battling with it. I'd like to quote from Gerald Harmon, who is the current president of the AMA, who wrote a very nice, sobering piece in the most recent material we received from the AMA. And quote, "The sad truth is our nation surpasses the unimaginable toll of 1 million official deaths to COVID-19 is the deaths that have been underreported since the pandemic began more than 2 years ago. We may never know the actual count, but we can all agree that the price we have paid in lives lost and the grief inflicted upon survivors is a price we can never afford to pay again. This is especially true for the estimated 200,000 children who have lost a parent or a caregiver to the pandemic." He goes on to talk about the fact that we have to do something to prepare ourselves and continue to battle this disease. One of the most important things, and we're not going to delve heavily into this tonight, but is that we must still be behind the vaccination effort. I know that when I examined the data of Illinois and specifically Cook County, even though we may have one of the better vaccination rates in the United States, within the Chicagoland area, they're really counting what they call fully vaccinated, which is the 2 primary doses of the vaccine. But when you look at the booster acceptance rates, we're down still below 50%. And this is problematic because, as we will hear more as we go on, we're now dealing with variants of the original SARS-CoV-2 virus that are so different that our only hope is to be able to deal with this is to have the 3 doses of the vaccine if you're a normal, healthy individual, and 4 if you're immunocompromised or older. We as physicians can't take our eye off the target. Too many of our patients and possibly some of our colleagues somehow feel that the pandemic is over. And this is the furthest from the truth. And we're now going to examine in more detail what is going on virologically and talk about what treatments are available and try to understand a little bit better what we are confronting and have to deal with currently and in the future. So I'd like to now welcome our speakers for this evening, Dr. Vishnu Chundy and Dr. Katie Mullane, both of whom should be well known to you by now if you've attended any of our previous sessions. And hopefully you will find this informative and useful to you. Dr. Chundy.
Thank you. Thank you, Ed. Thank you for getting a reflection on 1 million lives lost here. So I named this Fast and Furious because my wife likes to watch that crazy series with the cars running around, which I don't like, but that's how the Omicron variants are coming out. And this, I think the Omicron variant should really be SARS-3 rather than SARS-2 because it's a much different virus than we saw in the beginning of the pandemic. Next slide. So we've had over 1 million deaths in the midst of the SARS surge, which not me, but other people have called Surge 3. And COVID fatigue is amongst everyone. Even the most diligent physicians I've seen are like, I got to go on with my life. And so people are taking risks. The risks aren't as great for death, but clearly there's still risks present. And relaxation of mitigation measures, not driven by science, but by public opinion. Because if you just follow what the CDC has said before about test positivity rate and the amount of transmission taking place, we should be masking. But the public doesn't want to mask, and public health officials have kind of given the elected officials the ability, to advise them, but they've been pushed back, and now you've got masking basically non-existent. I was at a White Sox game on Sunday with the Yankees, which unfortunately we lost, and myself, my son, and my daughter were the only ones wearing masks in the inside the areas there. So there is a decrease in case fatality rate and in ICU admissions, which is really important because not as many people are dying and not many people are getting admitted to the hospital, but there's still significant consequences to catching Omicron. Next slide. So not so fun facts, so coronaviruses we thought were going to be much more stable because it has this large non-structural protein 4 exonuclease, and basically it's a proofreading mechanism that corrects for errors. But what's happened is, this is some of the largest genomes of the RNA world, similar to DNA viruses. And the Achilles heel of all of this thought process was that it would be a stable virus, but almost everything that's been predicted has been to a large degree changed. There's a significant background mutation rate in mouse beta genoCoV virus, and this the spike gene protein has a mutation rate which is 4 to 5 times higher than the rest of the genome, and that's what the vaccines are made from. They're made from the spike glycoprotein. And so this spike glycoprotein, which looked like an easy target, has now changed so much in Omicron that even the earlier vaccines that they were designing for Omicron, the original 1 and 2, have almost become, is actually equivalent to the original vaccine because it's not very effective in preventing infection. It is very effective in preventing death and hospitalizations. And point mutations, especially in the gene for the spike proteins, are capable of increasing replication, transmissibility, and even lead to immune escape. And that's what we're observing throughout this now the 5th wave of the pandemic. Next slide. So these, apart from point mutations, you're getting insertions and deletions, which occur frequently, and large-scale SARS-CoV-2 sequencing data of over 1.7 million genomes with bioinformatics has revealed many such events, thousands of times. These occur especially at the spike region and have led to escape from neutralizing antibodies. And the big fear is you lose T-cell immunity because you have such a broad spectrum of immunity with T-cells. And that's the fear, that you're going to end up, and that's what's keeping us all alive. That's why you don't have so many ICU admissions. Our T-cell immunity is saving the day from our prior exposure to variants. Omicron variant has basically 3 deletions and 1 insertion within the spike, and 3 deletions in other genomic regions. A non-coding deletion in B117 SARS-CoV-2 leads to increased translational efficiency of the accessory interferon antagonist. It interacts with non-synonymous point mutations and increases viral transmissibility. And that's what we're observing. It's much more transmissible than the prior Delta and the prior lineages before that. Next slide. So what have we learned from SARS, from COVID? And this is kind of a small encapsulation. So science and discovery have been rapid and well communicated. I became a doctor during the HIV pandemic, which is still ongoing, and it took us many years to even think what was the cause of HIV, and then it took us 20 years to actually come up with drugs that were more than 15 years to come up with drugs that were effective. And communication of how great science has been and how well it's all been communicated between all parts of the world has not been done well. It's been poorly communicated with a lot of influencers and a lot of misinformation. It is not influenza, it's a coronavirus, and it's behaving as such. We thought, okay, you're going to get a shot once a year and it's going to change and it'll be fine. Well, that's not holding out, and Kate Mullane's going to talk about that a little bit. It looks like a lot of the ability to just insert and make a new vaccine is not so simple with Omicron. And in reality, Omicron should be called SARS-3 because it behaves so much differently than the original virus. And it's capable of repeated infections, even in vaccinated individuals, based on immune escape and viral changes. And so you're seeing people who've gotten their 4th booster and 3 weeks later get infected again with Omicron that's circulating. And COVID has multiple mechanisms of disease. Next slide. So most people with COVID have minimal symptoms, especially with Omicron, 10% will develop hypoxia, probably a lot less now. 3% will be critically ill, which the outcomes are associated with older age and male sex. And here's what we learned, which is interesting. This was published in Nature. Inborn errors of type 1 interferon immunity involving viral sensors of toll-like receptor 7 or toll-like receptor 3. It can explain critical illness in about 1 to 5% of the people less than 60. So, we used to observe young people getting sick and dying and we couldn't ventilate them. This may be one of the mechanisms. And then neutralizing autoantibodies to type 1 interferons, especially interferon alpha, interferon beta, are seen in 15 to 20% of people over the age of 70. And this highlights the importance of type 1 interferon immunity for protective immunity against acute SARS-CoV-2. That's why there's a direct relationship between older age and death with COVID. Next slide. And a small fraction of children and young adults develop this multisystemic inflammatory syndrome with COVID. And it occurs about 4 weeks after infection. And this is a disorder overlaps with Kawasaki's because it looks like it's a super antigen mediated toxic shock syndrome, except toxic shock syndrome occurs almost immediately. And it looks like this is due to hyperinflammatory immune response with activation of T cells and possibly by SARS-CoV-2 antigen. And there's a massive expansion of T cells expressing T cell receptor beta chain variable regions. And you can read the rest of it with variable reactive autoantibodies that's happening. Next slide. So the weird thing is you have a delayed presentation of weeks, which is not what happens with superantigens. And this seems to be, this could be explained possibly by a persistence of the antigen, of actually the virus in the gut. And this is based on biopsies, which show persistent coronavirus in gut weeks after all the symptoms are resolved. So virus persistence has been proposed as to be associated with a degree of activation of the immune system during acute infection with SARS-CoV-2. So this is something new, and it's nicely documented now. Next slide. Can you go back one slide? I think we skipped one. No, that's it. Go forward. I'm sorry, Ruby. Okay, so now we have this magical thinking that COVID is gone. Next slide. And you can see, based on what we've been showing for over a year from our world and data, that Germany, the United States, and South Africa, Germany has come down nicely, but the United States is bumping up. South Africa has bumped up a little bit. Next slide. So daily new confirmed cases. And you can see if you overlap it over new deaths, the deaths have been falling nicely and headed down. Next slide. And if you look at community level transmission, now the CDC has kind of altered the definitions subtly. So community level transmissions less than 10 is green, medium is 10 to 19.9, and greater than 20 is high. Less than 200 cases per 100,000 population in the last 7 days. So go to the next slide. So it looks like fields of green, as Hotez said in one of his talks. It looks like everything is hunky-dory because the community levels of transmission are, community levels of disease is low in the country. Next slide. But if you look at determining transmission risk, how many people are getting infected with new cases per 100,000 in the past 7 days and a positive nucleic acid antibody test, and if you look at what most people do, they do their home antigen tests. Next slide. And this is what you see, that there's lots of transmission taking place all throughout the country. Illinois, almost if you know anybody around you, they've been infected recently with COVID because there's lots of transmission taking place. The difference is that during the first part, when Delta was around, we had lots of deaths taking place. And now we're not having lots of deaths, we're just having lots of infections and people with seeing more long COVID. We're going to get to that. Next slide. And so Eric Topol said this is COVID capitulation in this country because we've decided, even though lots of transmission is taking place, we're not going to wear masks anymore and we're just going to go on with our lives, even in very high risk circumstances. Next slide. So what we're dealing with is, early we had the variants, and then we had the beta variant with the Delta variant, and we had the Omicron variant with the 4th wave. And you can see in South Africa what's going on now with BA4 and BA5. So right now we're dealing with BA1 and BA2, and now a sister of BA2, which is expanding. Next slide. Okay. So you can see that with the Omicron variant, it's basically eliminated all the other variants, and all over the world, all you have is Omicron right now. Next slide. And if you look at this, this cluster map here, you can see that the original variants that we saw, whether it's alpha, beta, delta, they were all close together. But once you get to Omicron, you're literally having dozens of variants out there. And right now we're having in the United States an outbreak of a different variant, which is Omicron 12.11. Next slide. And this is another way of expressing it, that it's all Omicron. Next slide. And these are the mutations of Omicron. There's lots and lots of mutations of Omicron. This is from Eric Topol. And one of the key ones is this L452R mutation, which helps it evade immunity. There's several that helps it multiply more. And the one that's the most efficiently transmitted right now is the BA2 12.1. And coming right up the rear there is BA4 and BA5 in South Africa. Next slide. This is a representation of all the different changes in Omicron, and Kate Mullane has previously talked about all the changes in Delta and Beta. Well, there's lots more in Omicron, and the current Omicron is changing even quicker. Next slide. And what does it do? Basically, there is efficient use of the scary part, which is a little mouse down there, which shows that there's efficient use of rodents, and then rodents and bats are the largest mammals out there other than humans as far as numbers that congregate together to allow efficient transmissions. You need about 250,000 of these mammals together to get good transmission of respiratory viruses. And then, of course, the effectiveness of our therapeutic antibodies has gone away. Remember, sotrovimab, don't use that anymore. We don't use all these others. Now what we use is basically BAM-EDI. That's the only one that seems to work right now, and that's the one that we're using. So the neutralizing antibodies, you need lots more vaccine to get some level of neutralizing antibody, and then it drops off fairly quickly. Next slide. And this is the COVID tracker. Let's see if I can get it working. I can't get it working. The COVID tracker. What happened here? One second. I did something to my screen, Ruby. Can we go to the next slide, Ruby? Okay, let me try to make this bigger here. So what you're looking at, if you can just excuse me for a minute, I've got to get this to get bigger. No, it's not you, Ruby. It's me that screwed it up. No. Fit to do. I did something here to my slide. Excuse me for one sec while I try to get my Zoom back on correctly. View options. Full screen. There we go. Sorry about that. Now I got it back. So if you look at this slide, this is nowcast as of May 7th. The BA2 variant was the dominant variant till BA2 12.1 took over. And BA2 12.1 a week ago was more than 40% all over the country. And you should go to this nowcast on CDC, and you can see how rapidly BA2 12.1 is taking over. It has a transmission advantage and doesn't cause severe disease in most people. And you can see that BA1, which originally was the virus that was that was in this country, has gone away. And we're seeing this series of Omicron variants coming up. Next slide. Can you go to the next slide, Ruby? Go to the next slide, Ruby. Why is this so big? I'm sorry, I'm having all sorts of issues with the screen here. No, it's too small. Something's going on with my computer here. Okay, there we go. Now I can see it again. So, I'm sorry. So preventable COVID deaths, if you looked at if everyone was vaccinated with a primary series of vaccine with 3 doses, from June 2021 to currently March 2022, we could have prevented 234,000 of these 1 million deaths. That's a lot of, excess mortality we've seen. We've seen it amongst our physicians, we've seen it amongst our nurses, we've seen it amongst our friends and families. And that's the sad part about all this. And this is why vaccination still is important, because it does decrease mortality. Next slide. Okay, now it's not changing the view. And this is a different way of expressing the number of people who are unvaccinated. And the sad part about all this, if you look at the dark blue of unvaccinated non-elderly, it remains the same. Unvaccinated elderly from January 2022, it's still quite high. And then if you can see how many people are boosted, it's increasing, but it's still a small number. We haven't crossed the threshold of 50, 60, 70, 80% of vaccinated and boosted elderly. And today, when you talk about fully vaccinated, you need at least 3 doses of vaccine. And if you're over 50, you should get your 4th dose of vaccine now, because you're now having significant amount of transmission. And this will help boost up your T-cell immunity, especially if you're over 65, when you know that your immunity is waning. Next slide. And share of adult population by vaccination status, and this is from the Kaiser Family Foundation. And you can see fully unvaccinated adult population still is now down to 22% by February 22, and fully vaccinated is about 78%, which is considered 2 doses there. Next slide. And I'm sorry, go back to that one slide. And you can see the number of deaths is still predominantly in the unvaccinated people as of January 2022. Next slide. And if you look at what's going on in Chicago, the good news is we've had 0 deaths, but the positivity rate is 6.2%. It was like 1% almost a month ago. And now you're having a 6.2% positivity rate, and masking is being considered again, but there's a lot of debate going on back and forth. Next slide. And this is the wastewater that we talked about a while back. And you can see the red cluster right around Chicago. Florida has decided not to test. Some of these states have decided not to test, but around San Francisco and some of these other areas like Nebraska, you can see that the rates are still increasing in these areas for wastewater. So the rates continue to increase for wastewater, indicating 2 to 3 weeks from now, you're still going to have increased transmission throughout this area. Next slide. So what's changed? Next slide. So what's changed is the virus has changed, and the virus has changed not in a good way. It's fundamentally, compared to the receptor binding protein of BA1 and BA2, there's 3 additional mutations: this T376A, this D405N, and this R408S, and it lacks this G446S and 496S of the BA1. And the S371L on BA1 is substituted by a 371F, resulting in resistance to multiple antibodies. That's why the prior antibodies, monoclonal antibodies, do not work. And BA2 12.1 is very similar to BA2, except it lacks the L452Q and the Ferritin the F486 substitutions. And this has allowed it to have much easier entry into the human body, and that's why you're seeing it gain momentum. Now, we're not seeing a whole lot of BA2.13, but in South Africa, as we'll get into the future, you're seeing a lot of BA4 and BA5, and these have the L452R and the F486V. Next slide. So this was first identified in Canada in mid-January, and this L452Q mutation seen in the spike glycoprotein increases the infectivity of the virus, and it was previously not, and it's not seen in BA 12.1, but not, it's seen in BA2 12.1, but not BA2 variant itself. And it was previously found in the Lambda variant, and now it accounts for over 43% of daily cases. And bebtelovimab is still active. I'm sorry, I put in my monoclonals. Bebtelovimab is the one that's still active, not BAM-EDI. Next slide. And BA4 and BA5 is something you have to watch for because it emerged in Botswana in November 2021 and has now become the dominant strain in South Africa. And if you remember, Omicron started in South Africa and it's taken over the world. BA4 was detected in Limpopo and now is 35% of the strains, and BA5 was found in KwaZulu-Natal and now accounts for 20% of the strains, and collectively they're over 50% of all the infections in South Africa. And you got to remember, in South Africa, they're much younger people in South Africa, and over 90% of the people had natural infection. The vaccination rates are not very high, so natural infection does not protect you against getting infected from this, but it does protect you against death. Next slide. And this is South Africa, which is now in their 5th wave. And you can see the rates are very high throughout South Africa. And some of these areas are simply not reporting as high, but eventually all of it will become purple. Next slide. And this is their national COVID-19 hospital surveillance. You can see the vast majority of the people admitted in South Africa are not in the ICU, they're in the general ward, but the increase has been significantly higher. The number of deaths is not very high, but ICU admissions are 190. So the rates of admissions in the general ward is increased, but the ICU admissions and critical care admissions are less. Next slide. So if you looked at pseudo-neutralization assays for this, BA4 and BA5 have higher transmission advantage over both BA2 and BA2 12.1. It has lesser ACE2 receptor affinity, so it gets in a different way. It has immune evasion, and BA4 and BA5 have immune evasion with loss of neutralization. And the study suggests that BA1 vaccine may not be an ideal antigen for inducing broad spectrum protection. Next slide. And you can see on this that bebtelovimab is still active against the Omicron variants. Next slide. Running out of time. So what's the hope for the future? This was published in Nature, which looked at a sortase A tag receptor binding domain. And this is a very stable part of the coronavirus, and it's basically found in most coronavirus species, so in these viruses. So they took sortase A tagged ferritin with a nanoparticle, and this is a conserved portion which is not constantly changing, and they gave it to monkeys. Next slide. And it was actually protective against SARS-CoV-1, SARS-CoV-2, and most beta coronaviruses. And it had neutralization, which was effective at very high titers for a very prolonged period of time. So this vaccine has basically hopefully will help us get over getting repeated doses of vaccination to prevent COVID deaths. COVID infections, I'm not so sure about. Next slide. So what is long COVID? This is what we're all worried about. So it can occur in about 10% of infections, even with minor infections. Wide variability, can be mild to severe debilitating disease, and a variety of organs are involved: heart, lungs, neurological, autonomic, skin. It's difficult to, and right now the WHO classification is difficult because it also includes a lot of psychosomatic symptoms, and it's very difficult to distinguish from the post-critical illness syndromes. Next slide. And this is from Nature, which was actually a quite nice slide, which shows that there's different mechanisms with superantigen causing, fever, headache, and then you can get autoimmunity causing neuropathy, chest pain, palpitations, and then you can get viral persistence causing dysmotility, loss of appetite. So there's multiple mechanisms of fundamentally causing this long COVID. Next slide. So what do you need? I think we need a better definition. In England, there's actually a working group from the Imperial College, which has put together a nice definition. We need more access for care for patients. If you call up today and try to get into a long COVID clinic, it's forever and a day to get in. You need community physicians to be involved so patients can have access to latest science, and you need to advocate for appropriate therapeutic modalities for these folks with long COVID. Next slide. And what does all this mean? What you're observing in real time is a lot of immune pressure from natural infection and from vaccination, and this virus escaping this. Rodents seem to be playing an important role in reservoir species, especially in the developing world, where there's lots of grain that's kept in the villages, where there's lots of immunocompromised hosts and people with very low vaccination rates. And so they're acting as not just a incubator species, but also recombining with possibly with mice, coming back into humans and causing more disease. The vaccine development of the highly variable spike glycoprotein will be insufficient to prevent transmission and infections, but is good for preventing death. And what we need is a pan-coronal viral vaccine. I think that's all I have, right? Yeah. So, Ed, I think, oh, we have Katie here, so I will mute. Kate?
I'll unmute. Is there a slide before that one, Ruby?
No, it was blank.
Let's see. Okay, well, I guess we'll kind of talk about where we are with the vaccines against the Omicron variant. So based on either messenger RNA vaccines or the adenovirus vector vaccines, we know that when people have had 2 doses of vaccine, the longer the time period that you have after the vaccine dose, the lower the efficacy. And it really takes a boost of another dose or the 3rd dose, and now in adults, the 4th dose, in older adults, the 4th dose, in order to have antibody titers high enough. And why is that important? Well, there's a couple reasons. One is that the spike protein does not show itself to our immune system until right before it hooks onto the ACE receptor site. And so with the change in the structure based on Omicron mutations, that ability for our immune system to even see that immunogenic portion of the virus goes down. And so we need to have high concentrations of antibodies present ahead of time to be able to prevent the virus from causing infection. And then, as Vishnu said, the vaccines that we have do give us some T-cell immunity, but it takes a bit for the T-cell immunity to come around. And the virus does have ability to hide from allowing the T-cells to see it until late, which was the whole issue of us having cytokine storm afterwards. And that is still true. Then when we look at older adults, the number of free T cells and the number of free B cells that aren't already utilized for other antigens is lower. And so the ability of people to make good immune responses goes down as we get older. And so having multiple doses of the vaccine to remind the immune system of the virus is true. And this is really no different than we see with things like respiratory syncytial virus, because people can have multiple infections of RSV through the same season. And so we should not unexpect that with the coronaviruses. Next slide, please. So this was the data that was generated from Qatar and published in New England. And they looked at people who got 2 doses versus 3 doses of the vaccine. And those who ended up with symptomatic Omicron infection. And as you can see, the number of people who had infection with Omicron with 3 doses of vaccine was significantly lower than those people who had only 2 doses of the vaccine. And that was the initial data that showed us that we needed to have a 3rd dose of vaccine in individuals. We saw that not only with just infection overall, but as well with critically ill and fatal infections. Next slide. That was as well seen with Omicron versus Delta. And this was in England, where they looked at immunocompetent people who had vaccines, either 2 or 3 doses. In those people who had Delta, the vaccine efficacy with 2 doses was 61% versus 6% with Omicron. However, when people got boosted for Delta, the vaccine efficacy went up to 88%, and for Omicron to 51%. Next slide. So when we look at neutralizing antibody titers for Omicron in people who got messenger RNA vaccines, which are certainly the lion's share of the vaccines that were given, you can see over time from 1 week after the 3rd dose to 2 weeks after the 3rd dose, where we start seeing a nice response, that antibody titer by 8 weeks starts falling to the point where people tend to be at risk again. And that's not only in people who just were vaccinated naively, not having had a coronavirus infection, but on the bottom right is people who had infection and subsequent vaccination, that those patients as well had a fall in their original antibody titers, but were boosted when they got another dose of vaccine. So next slide. And this is looking at Omicron BA1 versus BA2 in Sweden, where they saw that the vaccine efficacy really was not much different between efficacy against BA1 and BA2. And that was at least somewhat reassuring, although not reassuring overall that it's less active than it is against the other Omicron variant or the other SARS-CoV-2 variants. Next slide. So we're in search of a variant-proof vaccine. This is not the only virus that we're in search of a variant-proof or a vaccine that is covering all aspects of viruses. We've tried for years to have a pan-influenza virus and a HIV virus vaccine, and we're still not there yet. But there are multiple platforms that are under consideration for trying to find a pan-coronavirus vaccine. So the mRNA platforms with multiple different variants covered, the self-replicating RNA, messenger RNA vaccine platform, the DNA platform, protein nanoparticle technology, and then combinations of both the viral vector and then boosted with other forms, either mRNA, DNA, or nanoparticle vaccines. The other thought is, as Vishnu was talking about, we're seeing that spike is not the only important portion of the virus that is allowing us to be infected. And so therefore we need to look at other parts of the viral proteome for neutralizing antibody sites. When we look at coronaviruses too, there's multiple species. So we have the SARS coronaviruses and the beta coronaviruses, but also the general coronaviruses that cause the common cold. And so it's not just one single virus family that we're looking at, but multiple families. Next slide. So these are some of the newer vaccines that are coming down the pipeline, those that are either just past phase 1 or further. The US Army has a Ferritin nanoparticle vaccine that is adjuvated to enhance the immunogenicity. And they're looking at that as a booster. And this is the original Wuhan strain. And they're looking at giving this vaccine after people have had either coronavirus naturally or have been vaccinated with other vaccines first. Duke University is using the Washington strain, which we know is already a variant from the original Wuhan strain. And they're looking at the full length of spike, not just the receptor binding domain, to see if they can get a better coverage or pan-viral vaccine. And it has human, bat, and pangolin virus genomes that are involved in it. Gritstone is actually in phase 3, and in Europe, it was supposed to start here in the United States, but didn't get off the ground, primarily because it's harder and harder to get sites to do vaccine trials because there's no naive patients here. So it has immunogenicity similar to that seen with AstraZeneca, J&J, Moderna, and Pfizer in those who are over 6 years old. And it is a self-amplifying messenger RNA. And so the thought with this vaccine is that it may have a better ability to have the body's ability to make new antibodies as variants come down the pipeline. The next one is from Immunity Bio, and this is a dual antigen spike and nucleocapsid antigen vaccine, and it's built around the adenovirus vector, and it's looking at boosting for the J&J vaccine. MigVax is an oral subunit vaccine, and the thought for that is to try to get better amounts of IgA so that we have surface mucosal immunity against the vaccine. And this is adjuvated with a bacterial toxin to try to enhance the immunogenicity of the vaccine. The SK Bioscience, which is Korean, is looking at a multi-epitope nanoparticle vaccine that has 3 to 4 receptor binding domains from bat and human, and it's looking to go forward as a booster vaccine towards the end of 2023. For Caltech University has also been working on a multivalent pan-sarbecovirus vaccine with 6 bat viruses, 1 pangolin, and the human beta coronavirus. And in mice, it's been shown to have very broad protection, and it is going into human studies very soon. VBI is another technology. It is virus-like particles. So they're non-infectious viral casings that then have the genetic material of the virus attached to it to cause immunity or to stimulate our immune system. And it's trivalent. It has hopefully a pan coronavirus against Omicron and several of the bat coronaviruses, as well as MERS. The Dios Covax is a needle-free vaccine that's been developed by computational modeling of the different genomes of the multiple variants. And it is a patch that's put on and hopefully will increase uptake of vaccine in people who have needle phobias. And Moderna's kind of gone the other way. They're not even looking in this 1287 vaccine as a coronavirus. They as a SARS coronavirus. They're looking at it as trying to enhance the immunogenicity of older coronaviruses that, in addition to the 1273 vaccine, we may see enhanced activity for the newer SARS vaccine or newer SARS viruses. So not even looking at some of the variants, but they do have as well variant vaccines for beta and for Omicron that are in study right now. Next slide. So I think that Vishnu had said that we were going to do mostly a question and answer kind of session for this town hall so that we're not speaking at you all the time. And we did have some questions that had come up at a time. Is Dr. Lynn going to host this part?
Yeah, I'll be willing to. I know that the majority of the questions that were submitted, Dr. Chundi did answer them, and it's in the chat. I don't have any other questions other than listen to the chat. There was one question. It said, is your understanding of the degree of risk of an under 65-year-old that has been vaccinated with one booster and had Omicron infection? When should they get a second booster if no comorbidities? Well, so we're talking now about someone with hybrid immunity, which they were vaccinated and boosted, and they ended up being infected. So, Vishnu, when would you choose to give them another booster, since they're under 65, but let's say they're over 50?
Well, I think it's a complicated question because it depends on who you live with. And it depends on what circumstances and your risks are. If you're basically going to wear a mask and follow all of the appropriate, the Swiss cheese approach, which is masking, staying away from crowded areas, and doing all the things you're supposed to do, probably don't need a booster. And if you don't have anybody who's immunocompromised at home, that's a transplant patient, person who's 85, 90 years at home, because even if you get vaccinated, as Katie showed, your ability to prevent infection is measured in weeks, not months and months and months. It prevents you from getting very sick and dying or hospitalized. So if I'll give you my example. I'm going to go see my 87-year-old father. I'm the OG. I had the original Wuhan strain when it first came out, and then I've been vaccinated. And I decided, well, I'm 58, so let me get boosted one more time. So I have a period of probably 4 to 6 weeks, maybe 8 weeks, where my infection risk is lower because my neutralizing antibodies are high, but they'll fade quickly. So I can go visit my dad at this time, test myself, and I'm pretty confident that I won't infect my father. Okay, and that helps. But if I wasn't doing all that, I think you're okay. For yourself, you'll be okay. It depends on who you live with. Katie, do you have even more to add to that?
Well, I think that, yeah, I think that we're never going to get away from until we have a vaccine, or I don't think that herd immunity is going to work for Omicron or for any of the other coronaviruses, because it changes too quickly. And we have too many people that are unvaccinated, and because it's so spreadable. So I think the Swiss cheese that you talked about, if you're going to be in crowds, if you're going to be around people who are immunocompromised, you don't want to get them sick, or you don't want to get sick, you're going to have to be wearing masks, and you're going to have to be social distancing. And I don't think that's going to go away. And certainly in Asian countries, they know that already, and they've been doing that for years. And it's not a social pariah, and you're not a social pariah in wearing a mask there. And I think we have to get over ourselves here and kind of get used to it. And I think that's going to be our new normal. We hope our vaccines will keep us well and keep us from dying, but I think we're still going to have these viruses around.
Yes, the cynicism surrounding masking is also somewhat puzzling to me, because they are effective. And if you become a pariah, maybe that's good and people stay away from you.
So Ed, one question.
Because people stay away from you, yeah.
The Omicron variant, though, I think has changed the masking paradigm a little bit. If both people are wearing surgical masks, it's more effective. But if you're the only one wearing a surgical mask in a crowd, it is not as effective. And that's where you're going to get stuck talking about wearing N95 masks or 2 surgical masks to decrease the amount of viral entry, because it's so infective that wearing a surgical mask alone in a crowd that may be carrying a lot of Omicron, your risk of transmission is not insubstantial. It's significant.
I still feel that we shouldn't abandon masking, and we should encourage everyone to be wearing it. This is one of my frustrations with the messaging that's been coming out that's very confusing. And we shouldn't abandon these other mitigation strategies, because obviously we don't have the perfect vaccine yet. And so, the avoidance of crowds, or spending a lot of time in a crowded area, Right now, fortunately, the weather's improving, and at least in our geography, we can spend more time outdoors, which is helpful. There was a couple of questions here, and I know that we put up a slide, but I want to get to these questions. One has to do with the idea of this rebound phenomenon that's been described now with Paxlovid. It's this rebound phenomenon, and I know it's interesting, and there's some interesting theories behind it. Vishnu, what's your current feeling about it?
Well, you are seeing people who, after taking Paxlovid early on, Neutralizing with ritonavir, day 10, day 12 get symptoms again, and then there was one case report that looked at basically cycle thresholds, and it showed that the cycle threshold dropped, meaning you had a higher viral burden after day 10 and day 12. And it probably has to do with we're not giving it long enough, but this may be the outlier. It's hard to make a big deal about one case report. For the most part, 5 days seems to be enough. The rebound may be due to reservoirs that you're talking about, where you, again, have taken away that pressure with this with the protease inhibitor. Taking Paxlovid prophylactically doesn't work because it's a protease inhibitor. You need to have actively replicating virus. You know, it is noted. I think it's not that common. You may need longer courses of therapy. Kate, anything else about this rebound thing that people are observing?
Well, I think probably they did see it in the original Paxlovid study. So both, it was already reported. And so it wasn't a surprise that this would occur. It wasn't really advertised in the studies or well delineated in the studies that it did happen. And so I think that it's something that for Pfizer was not unexpected to happen. It isn't going to be a lot of people, but the people that we most worry about are, of course, the immunocompromised people who, just like with influenza and with Tamiflu, they may not respond to therapy, and they're the ones that are going to be carrying the virus. And then we get concerned about the risk for resistance because in that population, they will continue being infected, and we don't know if they should be treated longer up front or not. And that goes along with the elderly who are immunocompromised. Is 5 days enough for them compared to a young person? And I think we don't know well enough yet.
Thank you. So going to the Q&A slide here, I think you may have touched on, Vishnu, already the answer number one. Are we in the fifth wave of the pandemic?
My vote is yes. I mean,
Yes, that's mine too.
I think
it's a different wave. We don't have as many hospitalizations or death, but the hospitalizations are certainly increasing.
Right. And to question two, we do know that vaccines do work, as we said, maybe no longer as effective in preventing quote unquote infection, which could just basically be, you know, a mild syndrome or a positive test, but it still has been showing to decrease significantly the hospitalization and death rate. What measures can we take to decrease the risk of infection? Well, we talked about those mitigation strategies, that we shouldn't abandon them completely. The pandemic is not over, and we're still at risk for getting disease, and we have to be very respectful of the fact that these mutations may not continue to be the mild kind, and we could be confronted with a disease that's more severe. Does it matter if I get infected if I am healthy? Well, that's an interesting question. I'll let you talk about that, because as I think you touched on it a little bit, it depends who you live with.
Kate, you want to take that one?
Well, certainly you can, depending on who you live with, you can cause harm to either your patients or to family members. The other thing is long COVID, and that's a very big concern, especially from the paper that is circulating, looking at, ghost viruses hanging around in us for long periods of time. Could that be the reason for long COVID? we don't know. And the estimates for management of long COVID are $17 billion. And we don't know long term. Is that going to increase the risk of early dementia? Is that going to increase the risk of cardiovascular disorders, renal dysfunction? I think all of those things are concerning, and we just don't know the answers.
Yeah.
Yes, I again, this idea that, well, we're all going to get infected, so let's get it over with. I think it's an infection that we should still be trying to do everything we possibly can not to acquire because of the things that you've pointed out.
So Ed, one thing to add, even people will get these repeated waves of infections. I mean, I've had these young people go out and get infected 3 times in a matter of 4 months. And they're still highly viremic at that time. They get endotheliitis, and nothing stops them from having a PE, DVT, stroke, and I think so I tell them, wear a t-shirt, don't catch COVID, because it's not safe.
Right. So the next question, what is considered up to date on vaccination? So remember, this is CDC speak. So fully vaccinated are the first 2 basic doses of the mRNA vaccines, or the single J&J. Up to date would mean that you have received the booster doses that's recommended based on your general health and your age. So for people up to the age of 50 who are immunocompetent, it's a single booster of either the mRNA, either a vaccine. Just as an aside, I just heard today that the FDA has approved the Pfizer BNT product for those children between 6 and 12 years of age who have not been eligible for a booster. And we're waiting for the CDC opinion on this. And my guess is they will go along with it. And so this will become available. In terms of the additional booster or the 4th booster, again, if you're immunocompromised, there's a different schema where you'll be getting these boosters sooner rather than later. But if you are immunocompetent, it's over the age of 50. It's been recommended for the 4th vaccine, which would be the 2nd booster. And those are the current recommendations. Now, another very important thing, and this follows what we've been saying previously about pregnancy, is the routine use of the J&J vaccine has now been, it's not recommended. And this has to do with a rare, but still a very severe concern about thrombotic embolization and stroke related to platelet aggregation, which seems to be triggered by this platform of the viral vector vaccines. The exception would be those individuals that have a contraindication, the mRNA vaccine, or those individuals who just refuse to accept the mRNA vaccine, only want the J&J. In that case, the risk from the vaccine is still less than the risk from the infection itself. I don't know if we have anything else you want to add to Vishnu or Kate in terms of that question.
No, that was very thorough.
So number 6, if I get infected, what should I do? Who should get Paxlovid and who should get a monoclonal? So I'll toss that out to my colleagues who actually use these medications.
So, both are under EUA. Paxlovid is both have a similar sort of profile, which is a higher risk person, over 50. Monoclonals we prefer to give in people who have interactions with Paxlovid, and they're not exclusive of one another. Monoclonals give you basically a monoclonal antibody, which gives you protection right away. Paxlovid is a protease inhibitor, so it has interactions with nirmatrelvir and ritonavir. The Paxlovid you'd have to take for 5 days, leaves a metallic taste, causes diarrhea, and it's very effective. I mean, if you look at the trials, your mortality rate is negligible for all of these. So, there was a question that popped up, when can you use both? Well, I did use it on a person who was severely immunocompromised, who had a very high risk for progression, but that's a rare exception to the rule. Usually one is all you would need. And the monoclonal does give you a good protection. It's not perfect, but it's pretty good. Okay, anything else?
Well, I think for my immunocompromised people, I tend to use both because of my concern that they won't clear with the Paxlovid on a 5-day course. And so in those patients, I do give both the antibody and Paxlovid.
As my mentor, Dr. Weinstein, used to say, the belts and suspender routine.
Gee, that was a contraception analogy that we used to use to prevent STIs. If traveling, what should I do to prevent infection?
To be sure.
Yeah, exactly.
Yeah, I think traveling is a big deal. Everyone is traveling, and you can see by the price of tickets right now to go anywhere. And no one's wearing a mask on an airplane or in the airport. And I think that's your biggest, if you look at the coronavirus, the SARS-CoV-2 pandemic, even SARS-CoV-1, airports and the travel points were where people got infected, and in airplanes. The lobby for airplane transportation have succeeded and won the battle, but they'll eventually lose the war if there's a mutation of this virus. So please wear your N95 mask when traveling through the airport in high-risk areas, and use a layered mitigation strategy. Stay away from crowded areas. Don't eat in these airports where everyone's congregating, because you will get infected. I can guarantee you will catch this current Omicron variant because of how transmissible it is.
Yeah, at the risk of being anecdotal, virtually everybody that I know personally and I've consulted with who've become infected, there's been a recent travel episode. Again, that's anecdotal. And I think some interesting studies that have been done showing that, yes, airplanes have great ventilation systems when they're turned on. But there's significant times during the boarding process and when you're sitting there and they're trying to conserve fuel and they're not turning them on. And it's also depends who you sit next to. And people don't remain seated completely during the flight, especially long flights. And so they've actually tracked infections throughout the cabin in some elegant studies that were done a while ago, actually, that I have read. So just I think a good high quality, well-fitting mask is your best strategy, as you pointed out. Pregnancy, that's something that's near and dear to me. If pregnant, what is my risk to the baby and what should I do if I get infected? Well, we're talking about an individual who becomes infected who's pregnant, and pregnancy, unfortunately, is considered one of the high risk factors for the coronavirus infection. Also, there are data that have reinforced the reality that women who become pregnant are at greater risk themselves for intensive care admissions, for ventilatory support, and even death. The biggest risk to babies is prematurity, because there appears to be a higher risk of premature delivery. The virus does not necessarily infect the baby directly with a high degree of incidence. There have been sporadic cases that have been reported, and some of these have been devastating. However, when vaccinated, all the news is good. The pregnant woman is protected, and now we have increasing evidence that the baby is protected, and this protection may persist in terms of passive immunological enhancement into the neonatal period. If a woman gets infected, she should be treated just like a non-pregnant patient. I think the current, and correct me if I'm wrong, Katie and Vishnu, the current monoclonal antibodies are okay to use in pregnancy now, the ones that are effective, that we're currently recommending, as well as Paxlovid.
Yeah.
Yes, there's no contraindication to giving monoclonal.
Would you do anything different with a pregnant woman who is infected?
To me, I treat them as regular. If they're sick and they need treatment, they get treatment.
Exactly, and I think that's really the take-home message. Okay. I think we've covered the long COVID.
Yes.
Unless you want to add, I think we've done that pretty.
I think testing strategy is important here. What is the best testing strategy, Ed, if we have visitors? Because I think there's a lot of mixed messaging with when people can return to work, and how long do I have to be off if I'm positive? Because there's been a lot of bad messaging, because everyone thinks 5 days later I can go back and do what I want.
Right.
And the data shows that you can shed virus even if you're fairly asymptomatic for up to 8 days, usually maybe 10 days, but really not beyond 10 days. So if you're going to go back after 5 days of infection, you should be testing. And if your test is negative with a lateral flow assay, which are the tests that are being sent out to the home, you're pretty safe to go back, provided you're asymptomatic. And if you're having visitors, serial testing with these antigen tests is fairly effective. If you have 3 negative tests on 3 separate days coming in, that's a pretty good, that's pretty sensitive test to make sure you're negative, provided you remain asymptomatic. And then when can you return to work if infected? If you have a testing strategy and you're asymptomatic after 5 days if you test negative, or after 10 days if you're not testing. I think most people agree on that.
I think number 12 we've answered, I hope, during the lecture. I'll take my prerogative. And number 13, as I mentioned, should I get my children vaccinated? And I know we, unfortunately, Dan Johnson, our pediatric colleague, was unable to participate tonight, but I think he would urge yes in terms of getting vaccinated. And now, more importantly, in my opinion, is the news is that we now have a booster strategy for those children under the age of 12. And hopefully, and we keep on saying mid-June, and I don't know, Katie, if you know anything more about the pediatric vaccine for the under the age of 6 children is still being evaluated, and we don't have any data on that yet.
I don't know the data for Moderna, I know, has been submitted to the FDA. I don't know about Pfizer's.
Right. I know Pfizer, I still think, is looking at the dosing scheme, in their product. There's some other question that just popped into the question. I think it was answered about the Evishield question. And
it still works, and certainly for immunocompromised people, we have been checking antibody titers in those patients. Many of them have no antibodies present even after 4 doses of vaccine. And so it's really important, if you have those patients or people that you have reason to believe that they wouldn't respond to any of the vaccines, because we have so many people on MIBs, NIBs, IBs, and MABs now, that if their antibody titer is less than 1,500 for spike, they should probably get Evishield.
okay, there was one last question that I think I'd like to have this answered, because I think this falls into some of the issues that we hear about. And the question is there a disadvantage in responding to future vaccines after taking 2 booster shots? Because I know we've heard this allegation that if we get boosted, we may nullify our ability to get better vaccines in the future. And I want to toss that out there. I'll start with Katie, because you're the one that is most involved in vaccine development.
Well, we haven't seen that happen yet. That's always something that is in the back of everyone's mind. We have no proof that has occurred. And, I don't know in the future if that will be an issue, but at this point in time, we don't believe so.
Yeah, and that's kind of the readings that I've done, and especially looking at the way these newer cutting edge vaccines are being developed, they're really looking to a different attack point. And I don't think we're going to be nullifying the effectiveness. Vishnu, do you have any comment about that?
No, I think it's,
And we certainly,
go ahead.
we give flu vaccines every year. I mean, and people have had them for many, many years now. So we sometimes pick the wrong variant that is going to be circulating. And we know that as people get older, their immune response isn't going to be as good, but we still see immune response to it. So I think that it is theoretical, and I hope that we never see it. But I think the likelihood is low.
Well, I'd like to wrap things up. We went over a little bit, but I think the information was important, and I'm glad that people stayed on. And again, I thank the Chicago Medical Society, and most importantly, I thank my colleagues, Dr. Vishnu Chundi and Dr. Kate Mullane, who really gave us a scholarly crash course in what's happening in the world of this very persistent, very fascinating, but somewhat demoralizing infection that we've been battling with as a country and in the world. And I thank you very much for your eagerness to share your ideas and thoughts. I wish you all good health and stay safe and stay healthy.
Thank you.